So hello everyone, welcome. So it's my first time hosting this call, so I'll quickly introduce myself. I'm Pascal Lissouba. I'm an epidemiologist from Epicentre and also an IOA core team member. Today's session will focus on IOA and sexual and reproductive health, a topic that is often either neglected or at least underrepresented in outbreak and humanitarian response. So we have two very excellent presentations planned, which will focus on the triangulation of evidence and the use of multiple data sources to help us better understand issues in sexual and reproductive health. And the two presenters will also share lessons learned and recommendations for advocacy, research, and practice. So the first presentation by Professor Lenka Benova from the Institute of Tropical Medicine in Antwerp will discuss the lessons learned from the COVID-19 disruptions to understand the bottlenecks in maternal care access and quality. And we will take the time for a discussion after the second presentation, but please do not hesitate to post questions in the chat as we go in the meantime. So Lenka, if you're ready, the floor is yours. You can share your screen.
Great, thank you, Pascal, and good afternoon. A very sunny afternoon from Antwerp. We cannot always say that, so it's lovely to be here, and thank you all for joining. My name is Lenka. And thank you for the invitation to join this call. What I wanted to do is maybe spend the 10 minutes sharing with you a little bit about the research that we had done in the midst of the COVID pandemic and what we learned in this way about maternal health in terms of disruptions, but also about maternal health and health systems routinely, which these disruptions can teach us. So I will speak about the lessons specifically we learned in the process of conducting our MATCO study, which stands for the Global Study of Maternal Health Provision during the COVID pandemic. Just to start with, of course, at the beginning, sort of February and March 2020, I remember that we really needed good data very quickly about what we call the direct impact of COVID. And that means, how is this new virus, this new infection, impacting women who are pregnant? What is the severity? What is the mortality among pregnant women and their babies, right? So the stillbirth rate, what is the prematurity? Are they affected by infection with COVID? How much vertical infection is there happening, and how does that influence the newborns? So all these were very new questions that people who are closer to the clinical side of things were dealing with. Here at ITM, we chose to focus more on the what we call the indirect impact of COVID. And that is, ended up being a far bigger negative impact on maternal health, maternal and newborn health. And that, you can imagine as being everything but infection with COVID. So, for example, includes lower use of health facilities because women didn't want to get infected there. Or they couldn't get there. There was no public transport. There were curfews. Staff, healthcare workers couldn't get to where they were working, or delays in reaching, especially with emergency obstetric conditions, were very profoundly impacting women's survival and morbidity. And those of stillbirths, perinatal deaths, lower breastfeeding rates, as well as larger sexual and reproductive health outcomes, such as the lack of access to family planning, resulting in more unwanted pregnancies. And then women being in a much more constrained situation affected their exposure to violence, loneliness, inability to access mental health services in the perinatal period during pregnancy, but also in the postpartum period. And poverty, of course, as a result of lost job opportunities, had a huge impact on nutrition, on their ability to care for babies. But COVID also influenced health systems. And by this, I mean the way that health systems, health facilities, health providers adapted their practices towards pregnant women who are giving birth, and women who are in the postpartum period. And these two sections, the indirect impacts and the impact on health systems, is what we chose to study in the MATCO Matko study, which was composed of a number of components. But what I wanted to show you is these particular two. So what we did was we started quite early on in the pandemic. So already mid-March 2020, a global survey of maternal and newborn health workers that ended up being in 3 rounds and allowed us to see how things were changing. And at the end, we collected responses from about 4,500 healthcare workers from more than 100 countries. So we had the survey in about 13 languages in round 3. And we had a prospective study of 6 referral hospital maternity wards in 4 countries in sub-Saharan Africa. So very much in-depth context-specific understanding of what was happening in these hospitals. And we chose, I'm going to tell you a little bit about how we triangulate the results or the findings of these 2 studies, but effectively what happened is that we ended up using the responses to the online survey to highlight potentially harmful practices or issues, a sort of red flags. What are healthcare workers saying is not working or is impacting them? And then the study of the hospital maternity wards, of course, was informative because these are the kind of high volume, high patient load settings where a lot of the very complicated obstetric, but also COVID cases in pregnancy end up in these countries. And so the mixed methods here of the maternity wards was composed of quantitative data. So we looked at monthly routine data for about 20 indicators. We collected data qualitatively using photo. As you can see here, this is the antenatal care waiting area at the Muhimbili National Referral Hospital in Dar es Salaam. We conducted healthcare worker interviews, very in-depth Zoom interviews with people who were working in these hospitals. And we also looked at the guidelines, the scope of practices that were continuously changing during the pandemic. And our team meetings, of course, with the 4 country teams were incredibly informative and gave us understanding of what was happening, not just in the hospitals, but also in the countries. How were the mitigation measures impacting daily life? What were some of the issues that were not written, but understood culturally within these hospitals? So just to give you an idea of the changes, the adaptations to the care processes that we documented through these 2 studies during antenatal care, the visits or the schedule of visits ended up being postponed, or more time was taken between routine visits, in effect, resulting in women receiving fewer than the recommended number of visits, whatever those are in each country. And physical distancing between women and providers, either because this was a guideline, an adapted guideline, or usually by the preference of the provider not to come too close to the patient, ended up meaning that many women, for example, didn't have a close examination, or the baby's heart rate wasn't listened to during antenatal care because that was physically needing contact. During labor and childbirth, women, healthcare workers reported that fewer options for pain relief were provided to women. Birth companions were banned, visitors were banned because this introduced additional people to the facility, and that wasn't a protected component of maternal care. So they just got banned without an understanding of how this influences the quality of care and the women's preferences in childbirth. There was, of course, also less continuity of providers. Many facilities instituted a kind of emergency scheduling of providers. So they would have 24-hour shifts a few times a week, or they stayed on for much longer and then they went home for much longer. So women were not able to take care of the advantage of a continuity that they need for sort of emotional support. And of course, we heard reports of unnecessary labor augmentation to shorten the duration of labor, shorten the exposure of women to the facility and the facility to the women, which was not guided by evidence. In the postnatal care, in the postnatal period and newborn period, women were routinely discharged earlier, so they didn't take advantage of the continuous monitoring after childbirth. In the facilities, newborns were separated in some settings, not just newborns who had mothers with, who were COVID positive, but this was almost routine in some settings that newborns were taken away from the mothers for their own protection. which of course is terribly harmful for the dyad. Breastfeeding likewise was discouraged or disabled by this separation, and the outpatient follow-up postnatally was disrupted or minimized. They were also adaptations or change in practices that healthcare workers said were positive. What did they like that came out of the COVID pandemic? And the first and foremost was that hand washing practices were made easier for them. So sinks were suddenly had soap all the time, or there was a refill of buckets of water where they could wash hands, or the hand washing stations were actually at the point of care. Whereas, this has been an issue that we have been banging on for, since Semmelweis time. And suddenly COVID made that so urgent that it was possible to wash your hands at the point where the woman was delivering. So they really appreciated that. Of course, healthcare workers, and especially midwives and nurses, liked that there was more attention to training and skills building because they needed to learn new knowledge, new practices. And more indirectly, people appreciated the move to virtual communication. So, for example, daily meetings or weekly meetings of the team, because they were now on WhatsApp. It was easy to add all the nurses, all the midwives, and even the cleaners in this sort of more inclusive communication channels that allowed team building and team communications to flow. And this was particularly notable for, the sort of discrepant cadres where you have in facilities where you have most of the doctors being male and most of the midwives and nurses being female. This was really appreciated as an inclusive measure. And so my last informative slide is in fact on the triangulation, what you asked me to talk about. And we found from this many different sources of evidence, including a scoping review of literature on disruptions of healthcare in previous humanitarian or epidemic settings, is that it's not the virus that is disrupting access and quality of maternal care. It's the mitigation measures against the virus themselves. And so in that sense, the sort of two-way communication between the people, the authorities imposing these measures, and the people who are at the front line of providing this 24/7 care for women in labor or in babies is really essential, because when it happened, when it worked, and for example, when healthcare workers or facility managers were able to say, look, our midwives cannot get to work, they need some kind of exceptional badges or something to get through the checkpoints, or women are being stopped at checkpoints, you have to tell the policemen staffing them to let them through because we are seeing women die because they're coming too late. When that worked, it was magic. Things could be resolved within a few hours and some kind of continuity provided. When it didn't work, including in Belgium, there was a lot of other, grudges and discontent and sort of inability to find a way to connect during this disruption that actually led to unnecessary mortality and morbidity. We also note, of course, the interconnectedness of health systems is hugely complex, but there are connections. So we call this sort of what happens anywhere matters everywhere. And this is especially the case in referral hospitals. So referral settings, sort of the places that take care of most severe cases, are really at the mercy of the underlying health system. If people cannot get upwards, if people are not able to get referred, then the referral hospitals are for nothing. They are not able to make it happen, but also they are there ready. So when they only get people in severe morbidities, then it also affects their statistics, the survival that they are able to ensure. So it's a frustration, right, of the highest level that reflects really the disconnect within the health system. And we can also see, we all know, right, those of us working on maternal health, we know by and large what is not working already, but even we were surprised by some of the weaknesses that COVID exposed, which we didn't know were sort of weak links. And for here, I think One very simple example is, in high-income settings where we think a birth companion is a routine, unquestioned part of providing childbirth care, the speed with which birth companions, husbands, mothers, a supportive person to a woman in labor were canceled, were banned. It sort of made us question whether this was in fact a routine, well-accepted evidence-based intervention or part of care, which it should be, or whether it was just begrudgingly accepted for the time being and canceled at the first initial opportunity which COVID provided. But more generally, maternal and newborn services fell through the cracks. So, for example, how is it that midwives providing home-based visits for postnatal care were not considered frontline staff for priority in terms of masks and gloves? Or that pregnant women, knowing what we know about the effect of the flu or Ebola in pregnant women in terms of severity and mortality, pregnant women were not considered high risk from the very beginning of this pandemic, which ended up taking us about a year into the pandemic to find out from the very sort of high quality clinical data that people were collecting. And the last point on this interconnectedness for me is that our routine data collection, so specifically the routine data that we collect every month in every maternity ward, number of stillbirths, number of deliveries, numbers of maternal deaths, has to be flexible, because the most difficult of the 20 or so indicators that we collected was the number of pregnant women with COVID. And that is because it didn't exist in any of the columns that we provide. And this ended up not being collectible. So where did we get this data? From the WhatsApp groups of the healthcare providers, because there was a paper trail or electronic paper trail on the number of pregnant women which these referral hospitals were handling. And surely routine data systems should be flexible enough to capture a new indicator that is the most urgent thing at the, of the time or of the epoch. And from the methods perspective, I think we really highlight the fact that healthcare workers' voices and perspectives are really critical in research, whether it is in normal times, whatever that might be, or in the times of such disruptions. We were very surprised at, in March and April, when people were extremely busy, extremely worried about their health and the health of their families, they still wrote so many qualitative insights into this online survey. It really allowed us to gain an insight into these red flags, but just the time that they took, the willingness to share was really inspirational. And so was the resilience and their ability to deal with change. But what they said is this effectively, listen, we can do a different thing every day. We know evidence of about a new virus, can be changed. We learn something new, but please give us clear guidelines. The worst situation is when nobody knows what to do and there isn't the leadership or the teamwork to give people instructions about what's the right thing to do. So it doesn't matter how often it changes, as long as there is clarity. And of course, leadership of departments or even informal leadership within teams matters hugely in these disrupted times to people's motivation, people's ability to perform, to their flexibility when a new issue arises or things need to be set up for a particular woman with very complex needs. And so when we try to understand what happened, in my first slide, I said we try to understand how these indirect effects and the adaptations in the health systems they happen. They're obviously extremely context specific, but the key word here is complexity. And so I'm just showing this to you. When we try to figure out in these referral hospitals what happened and why, we have to engage a very good visual designer to be able to put all those linkages together and try to explain how it happened. And of course, things happen in different ways in different settings, and in-depth understanding is critical. But there are some overarching lessons, some of which I have shared with you today. So I want to finish by thanking the whole team in many different countries, and all the respondents and people who have been part of this research. Thank you very much. Over back to you, Pascal.
Just wanted to say that I thought both studies really made such a strong case on how, you know, maternal reproductive health services, you know, those are really important and they really should be prioritized in humanitarian settings, in outbreak situations. So I think it would be great if, and there were all these really cross-cutting topics, like the involvement of healthcare workers and improving routine data collection and like you said, Lenka, improving the routine practice, you know, so then, you know, we're better equipped to respond to outbreaks or humanitarian situations. So I don't know. I think it would be great if we could come up with some recommendations and hint, Simone, if IOA could maybe, I don't know, maybe collaborate with that. That would be really fantastic. So, okay. So thank you, Simone. So thank you, everyone.